as many of you know, persistent pulmonary hypertension has been a significant issue for primarily term babies and post-term babies for a very long time. And although we've made modifications and we're seeing much less meconium aspiration syndrome since our obstetricians have gotten more aggressive about deliveries after 40 weeks of gestation, we still see a great deal of primary pulmonary hypertension and pulmonary hypertension secondary to other conditions. So I was pleased that I was asked to speak on pulmonary hypertension. And coming from the original and still the largest ECMO center in the United States, we see a lot of referrals for pulmonary hypertension. These are my disclosures related to the content. And my objectives in this hour will be to talk a little bit about fetal and neonatal circulation, the physiology of transition. We'll talk briefly about biochemical mediators of transitional physiology and persistent pulmonary hypertension. I will talk briefly on nitric oxide pharmacology. We'll review the clinical evidence and close with some other inhaled pulmonary vasodilators which are appearing around the world in neonatal practice. Now, I think it's important to understand the history of this disorder, which has been both perplexing and frustrating. And although the original description of this was called persistent fetal circulation, based on the observations of Bill Gersony, who was a pediatric cardiologist working with a number of people at Columbia University, including Jack Sinclair. The actual description of fetal circulation dates back to William Harvey in his treatise on human circulation. In 1978, there was a publication by George Peckham and Bill Fox from Children's Hospital in Philadelphia, in which they showed the effects of hyperventilation on reversing pulmonary hypertension. Now, this was an important paper for two reasons. Number one, it helped us understand a little bit about the physiology, but it was a single case report. And one of the things that clinicians did not observe that was part of this case report was that although you could get a baby to respond to hyperventilation, it was only transiently useful, and that each time this particular baby was hyperventilated, it required a greater degree of hypocapnia in order to achieve a rise in oxygenation. And yet, hyperventilation became the standard of treatment for persistent pulmonary hypertension for the better part of a decade. And it was during this time that Jen Wang, as we got into what I called the amazing 80s, Jen Wang from Columbia offered an alternative approach, which was gentle ventilation, allowing high levels of PCO2, lower levels of oxygenation, and significant metabolic acidosis, thinking that hyperventilation was perhaps contributing to the genesis of pulmonary hypertension. And we had very radical differences in opinion during the 1980s about what the best management technique was. And you would think that with two disparate philosophies of dealing with pulmonary hypertension, that somebody would have done a randomized clinical trial. Well, we went to the National Institutes of Health in order to get funding for this project, and they turned us down. So, at least in the United States, for the better part of the 1980s, most people hyperventilated and pushed extreme alkalosis. Others used the gentle ventilation technique, and many babies ended up on ECMO. There was also a drug that was used quite prominently in the 1980s called telazoline. And this was a non-selective vasodilator. When it worked, it was like magic. And when it didn't work, it got the babies into extreme trouble. So eventually it was taken off the market. And the 1980s closed with a flurry of things happening. As I mentioned, ECMO became the standardized treatment for babies who failed conventional therapy, and then high-frequency ventilation came on board. And finally, the puzzle seemed to be solved with the advent of inhaled nitric oxide, a selective pulmonary vasodilator that didn't have the side effects of systemic hypotension. And many, I'm sure all of you have seen this slide at one point or another, and it just describes fetal circulation. And again, the key to fetal circulation is that the baby is still attached to the placenta, which really serves as the main organ of respiration, providing oxygen and removing carbon dioxide and metabolic waste products. And of course, nature has designed a wonderful bypass system by making the lungs a very high resistance end organ, channeling blood flow to the placenta through the foramen ovale and the ductus arteriosus. And as long as the baby is attached to a functioning placenta, everything is fine. But when the baby is born and the cord is clamped, the placental resistance goes to infinity, the lungs are inflated, pulmonary vascular resistance drops, pulmonary blood flow is established, and hopefully all goes well, as you saw from the statistics that Professor Sogstad showed you. Occasionally, though, this doesn't happen. Pulmonary vascular resistance remains high, and blood is shunted right to left through both the foramen ovale and the ductus arteriosus, rendering the baby profoundly hypoxemic. Now, to summarize the events of transition, with the first breaths, the fetal lung fluid is cleared, functional residual capacity is established, and surfactant secretion begins. And coincident with cord clamping, the low resistance placenta is removed and systemic resistance rises. A rise in oxygenation causes a further fall in pulmonary vascular resistance, resulting in increased pulmonary blood flow. Increased pulmonary venous return increases the left atrial pressure, which functionally closes the foramen ovale, and the increases in pulmonary blood flow, as well as the increases in oxygenation, decreases ductal level shunting. Left atrial pressure rises with ventilation from 3 to 7, and pulmonary artery pressure falls minimally from 53 to 47 following ventilation and oxygenation. And remember that vascular resistance can be expressed as the pressure difference divided by the blood flow. Now, pulmonary artery pressure is still elevated compared to adult values, but with increasing age, the pulmonary artery pressures decline toward adult norms, and mean arterial pressure initially falls, probably as a reflection of the increased vascular volume or vascular capacity as the lungs inflate, then rises slightly with cord clamping, and despite marked changes in blood flow patterns, there is little change in blood pressure. Now, this slide lists the mechanisms that are responsible for the decline in pulmonary vascular resistance at birth, and these include the removal of fetal lung fluid, the establishment of a gas-liquid interface, ventilation, increased oxygenation, and shear stress. So we can define persistent pulmonary hypertension generically as the failure to achieve or sustain the normal fall in pulmonary vascular resistance that should happen at birth. There is altered pulmonary vascular tone, reactivity, and/or structure, and the severe hypoxemia as a result of continued right-to-left shunting across the PDA and the foramen ovale results in significant acidosis, which further constricts pulmonary vessels. And the incidence is about 1 in every 1,000 live births. And this is just a little schematic showing the normal pattern of blood flow on the left side and abnormal blood flow with right-to-left shunting on the right side. And again, you see the abnormal path through the ductus arteriosus and the foramen ovale. This is a very difficult slide to read, and I apologize for that. But these are factors that can affect pulmonary vascular resistance. And on the left side, you see factors that lower pulmonary vascular resistance, and I won't go through all of these. But mechanical factors include lung inflation, structural changes in vascular cells, interstitial fluid and pressure changes, and shear stress. And factors that tend to increase pulmonary vascular resistance are shown on the right slide. These include both endogenous mediators and mechanisms and mechanical factors as well. Now, how do we diagnose persistent pulmonary hypertension of the newborn? Well, I think we should clinically suspect this when the hypoxemia is disproportionate to the degree of lung disease. And in fact, when Gersony made his original observation, he described profound hypoxemia in babies with clear lung fields. On physical examination, there is often a single loud second heart sound with fixed splitting. And I think the initial diagnosis can be suspected by doing dual site oximetry. So if you place a pulse oximeter on the right upper extremity and a pulse oximeter on the lower extremity, you may see significant gradient with the preductal saturations 10 to 15% higher than the postductal. But you can also be fooled if the baby is profoundly hypoxic, there may not be a gradient. So at this juncture, the gold standard of diagnosis is the 2D echocardiogram with Doppler color flow that will demonstrate right to left shunting. Now, if you don't have an echocardiogram or you don't have a cardiologist available, the bedside test to assess pulmonary hypertension continues to be the hyperoxia test. And here you place the baby at 100% oxygen for a period of 5 to 10 minutes and then draw a blood gas. If the PO2 is greater than 150, it generally will rule out both structural cyanotic heart disease as well as persistent pulmonary hypertension. But if it's less than 150, you're still left with the dilemma that it might be cyanotic congenital heart disease or pulmonary hypertension. On this slide, I've listed the spectrum of pulmonary hypertension. And again, we are going to concentrate primarily on immediate neonatal persistent pulmonary hypertension. Pulmonary hypertension can exist later through later infancy, and we see this particularly in our babies with bronchopulmonary dysplasia, and it may go into adulthood. Now, when I think about pathophysiology, I like to categorize things. It makes it easier for me to understand what the problem is and perhaps organize my approach. And so pulmonary hypertension has generally been divided into 3 categories. The first of these, you have normal pulmonary vascular morphology with myocardial dysfunction or increased pulmonary vasoreactivity. The second category involves morphologically or functionally abnormal pulmonary vasculature, and the third category involves structurally abnormal heart disease. Among the conditions that can lead to myocardial dysfunction and vasoreactivity include asphyxia, meconium aspiration syndrome, sepsis or pneumonia, thrombus or microthrombus formation, and something that we seldom see anymore, but we used to see quite a bit of, and that is hyperviscosity syndrome. This slide lists the causes of abnormal pulmonary vasculature. In this box, we see conditions that result in abnormal extension of the pulmonary musculature deeper into the pulmonary vascular tree. We see that sometimes in meconium aspiration syndrome, particularly if it's been chronic. In utero PDA closure, this is sometimes seen when mothers have taken non-steroidal anti-inflammatory drugs. Alveolar capillary dysplasia, which is a lethal anomaly, and idiopathic persistent pulmonary hypertension. The second category is when there are small lungs with decreased cross-sectional area, so that the entire blood volume has to go through smaller cross-sectional area, raising the pressure within those vessels. And we see this with pulmonary hypoplasia, congenital diaphragmatic hernia, and cystic adenomatoid malformation, or cystic pulmonary adenomatoid malformation. And the third category is hypoxia-induced. So if a baby has been subjected to chronic hypoxia in utero, this may stimulate abnormal muscular growth in the pulmonary arterioles. Structurally abnormal hearts that can result in pulmonary hypertension include left ventricular outflow obstruction, total anomalous pulmonary venous return, Ebstein's anomaly, left ventricular cardiomyopathy, and obligatory right-to-left shunting. Now, persistent pulmonary hypertension is a clinical syndrome that's associated with diverse diseases. And you can see this on the pie chart format. About 20% is seen in association with RDS, congenital diaphragmatic hernia, about 1 in 6, meconium aspiration syndrome, about 30%, pneumonia, about 10%, primary or idiopathic persistent pulmonary hypertension, about 16%, and other causes, about 10%. Now, one of the hallmarks of persistent pulmonary hypertension is often ventilation and perfusion mismatch, which you see in this cartoon. And normally, what we like to see is that an alveolus is appropriately inflated, has adequate capillary blood flow, and enables the exchange of carbon dioxide and oxygen without a problem. But sometimes we have difficulties where there are alveoli that are ventilated but not perfused, and alveoli that are perfused but not ventilated. And when ventilation-perfusion mismatch occurs, there is inadequate gas exchange, again leading to profound hypoxemia and metabolic acidosis. What about endogenous nitric oxide? Well, there is strong evidence that nitric oxide plays an important role in the circulatory transition at birth. But thus far, there is no direct evidence that infants with pulmonary hypertension have decreased nitric oxide production. Well, what is it then? Well, maybe there's an excess of vasoconstrictors. Maybe there are alterations in nitric oxide biochemistry and metabolism. Perhaps there is decreased quantity, decreased activity, perhaps decreased soluble GC, and perhaps there's increased nitric oxide metabolism through the phosphodiesterase 5 enzyme. Don't really know yet. Now, nitric oxide is normally produced by the cleavage of arginine in the presence of nitric oxide synthase to citrulline and nitric oxide. And this pathway was really it took quite a long time to work out. And Louis Ignarro is acknowledged as the person who first described the so-called endothelium relaxing factor as nitric oxide. And again, this is a little diagram of what happens at the cellular level. You see that nitric oxide is indeed produced and rapidly combines in vivo to relax vascular endothelial tissue and promote pulmonary blood flow. It's a very complex molecule and has many roles in vascular function. It can cause decreased platelet aggregation, decreased monocyte adherence, and polymorphonuclear leukocyte adherence, as well as vascular permeability. But its major role is, again, to facilitate vasodilation at the level of the endothelial cell. But it's also an anti-proliferative compound, and as many of you have probably read, it has been used in trials of trying to prevent bronchopulmonary dysplasia through this anti-proliferative effect. It's also potentially a very toxic drug if given in excess. Normally we control this fairly well when we're using it therapeutically. It can combine with hemoglobin to form methemoglobin, which in excess can lead to tissue hypoxia. It can form with oxygen to produce peroxynitrite, which is cytotoxic, causes surfactant dysfunction, and may result in acute lung injury or ARDS. And it can also form with oxygen to form nitric dioxide and other nitrites, which cause epithelial damage, airway reactivity, and even pulmonary edema. So we really have a very limited therapeutic window for this drug. Some have questioned whether inhaled nitric oxide might be cytoprotective or cytotoxic, and the roles for this are shown on this slide. Some of its cytoprotective functions include decreased vascular resistance, decreased smooth muscle proliferation, decreased thrombosis, decreased polymorphonucleoside adhesion, reduced oxidative injury, and decreased vascular permeability. But its cytotoxic effects include enzyme inactivation, cell death, nitrositive stress, surfactant inactivation, increased edema, and at least in some animal studies, it has shown to be mutagenic. I like this quotation that came from workers in a Chinese fireworks factory who said, "It is better to curse the darkness than to light the wrong candle." And I think that this really applies to any situation in which we use a drug that has a potentially very therapeutic role, but with unknown toxicities. And unfortunately, the history of neonatology is filled with good intentions that led to unexpectedly bad results. Now, I'm not saying that about nitric oxide. I'm saying it in general, and I'm going to show you as we end up that people who are looking for alternatives to nitric oxide maybe like the worker in the fireworks factory who lights the wrong candle. There are still some uncertainties in the use of inhaled nitric oxide. Who should be treated? Which centers should offer inhaled nitric oxide? What is the optimal dose and duration of therapy for INO when you're treating persistent pulmonary hypertension? And what is the role of adjuvant therapies such as high-frequency ventilation, alkalosis, or even exogenous surfactant? There are additional questions that have been addressed. These include, does inhaled nitric oxide delay the initiation of ECMO in centers that can provide it? Is ECMO avoidance associated with worse pulmonary or central nervous system outcomes? And what is the role of inhaled nitric oxide in treating premature infants? So let's look at the evidence. And a lot of this came from a very roundabout way in which inhaled nitric oxide was eventually approved in the United States by the Food and Drug Administration. It wasn't done through a characteristically performed level 3 randomized blinded controlled trial, but mostly from level 2 evidence that was collected by the Mallinckrodt company and based on anecdotal experience in many centers, which was contributed to the database. But some randomized controlled trials eventually emerged, and the ones that are highlighted here all appeared within a relatively short period of time. And these include the NINOS trial, the Synergy trial, the trials of Roberts and Wessel, and then the OMITA trial by the manufacturer. Excuse me. Now you can see they're all relatively small trials. The entry criteria was the oxygenation index, and we can talk about that later if you like. I don't think it's necessarily the best determinant, but because it was used in so many ECMO trials, it became sort of the standard criteria by which persistent pulmonary hypertension was scored. Not all of the studies required confirming echocardiogram, so there's a little bit of diversity there. And the control groups here were slightly different. 3 of the trials used nitrogen as the control inhaled gas, and 2 of them used 100% oxygen. So a little bit of disparity. But one good thing is that none of these trials was a crossover allowed. Kinsella had a trial of 205 patients, but in his trial, crossover was allowed. So when you use a crossover design, it takes away some of the differences, because you'll have patients who receive both arms of the therapy, and it makes it difficult to discern whether or not there's a real difference. Now, what did we learn from these trials? And I thank my good friend Reese Clark for putting all of this together. First of all, there were differences among the trials that included the maximum dose of nitric oxide that was allowed. 4 of the trials allowed 80 parts per million. The Synergy trial capped the dose at 20. It also limited the duration of therapy to 4 days. The other 4 trials used 2 weeks. And all but the OMITA trial allowed for high-frequency ventilation and exogenous surfactant replacement. Well, what do we learn from this? Nitric oxide certainly seems to reduce the relative risk for the need for ECMO. And you can see in the trials, the end result here was about a 50% reduction in the need for ECMO. It didn't change the relative risk of death compared to studies with bailout or the use of ECMO. And interestingly, compared to the ELSO registry data, which is at the University of Michigan and contains information on virtually every baby treated with ECMO in the United States since the mid-1980s. And what Dr. Clark did here was to compare the response by the diagnosis. And you can see it's very, very close in all cases to the survival rates that are reported by the ELSO registry. We still aren't doing very well with diaphragmatic hernia, and that should not come as a great surprise. But again, improvements in oxygenation and survival without ECMO is seen in meconium aspiration syndrome, pneumonia, primary persistent pulmonary hypertension, and even RDS. And here are the survival rates for this compared to the ELSO registry. So again, diaphragmatic hernia, we're not doing very well. It's about 55%. But for all other conditions, meconium aspiration syndrome, in excess of 90%, pneumonia, 85%, primary persistent pulmonary hypertension, 90%, RDS, about 80%, and in total, about 80%. So it really seems to have been able to replace ECMO as a rescue therapy. Another interesting question that came up is, okay, you can use inhaled nitric oxide instead of ECMO, but does that mean the baby's going to have to stay in the NICU longer? And the answer to that question here is a resounding no. That again, you see, even for babies with treatment failures, that the hospital days are really unchanged. Again, the outlier being the congenital diaphragmatic hernia. The same question was asked about, does it increase ventilator days? And the answer here is, again, even with treatment failure, there are no statistically significant differences. Again, the outlier is the diaphragmatic hernia. Now, when we first started to use nitric oxide, there was a great deal of discussion about how much should we use. And you'll find as you go back through the earlier literature that people tended to use a protocol where they loaded the baby by starting at 80 to 100 parts per million and then weaning by response. And here you see that in the 5 studies that were utilized in the meta-analysis, the responders in orange and the survival without ECMO in green, that it really looked like 10 to 20 had the same effect as 80 to 100 or 50 to 60. And this really helped us understand the concept of toxicity better. Now, this is a wonderful slide because it shows the methemoglobin level compared to the dose of nitric oxide. So here are hours of therapy, and here is the methemoglobin level. And you can see that when you use 5 parts per million, 10 parts per million, or 20 parts per million, your methemoglobin level remains less than 1%. But if you go to a higher level, 80 parts per million, you can see that after about 8 hours, you're starting to get into a very toxic range with better than 4% methemoglobin. And the same pattern is shown for nitric dioxide, that again, if you stay below 20 parts per million, you're in a relatively safe range, but if you go up to 80 parts per million, you can see how quickly the NO2 level goes up and remains elevated for the duration of that treatment. Now, what about adjunctive therapies? And I think this is something that we can thank John Kinsella for. He showed us that for meconium aspiration syndrome, RDS, and most of the other conditions, you got a much better effect when you combined inhaled nitric oxide with high-frequency ventilation. And he postulated that the reason that the combination was effective was you got much better lung recruitment and delivery of nitric oxide to the lung when this was combined. Now, I'm going to show you a film, two short clips. The first of these, these were done with a siliconized pig lung. And what you see here is conventional ventilation. And you see the rhythmic opening and closing of the lungs. Now, these are normal lungs, they're not diseased lungs, but you can imagine what happens if this lung were filled with meconium or pneumonia or had abnormal vasculature, that this opening and closing is going to result in a nitric oxide delivery being somewhat erratic. Now, if we go to the next slide, this is a lung on oscillation, high-frequency oscillation using the SensorMedics device. You can start it. Okay, don't worry, it won't explode. But you can see what happens with oscillation, how we apply a continuous distending pressure, super PEEP, if you will, so that the lung is completely inflated, and then we oscillate around this mean airway pressure to remove carbon dioxide. So clearly a more effective way of delivering nitric oxide. Okay, we can go back. Okay. What about using inhaled nitric oxide in cardiac disease? There have been some benefits shown in pulmonary hypertension when it's associated with total anomalous pulmonary venous return, congenital mitral stenosis, or treatment or prevention of pulmonary hypertensive crisis after cardiopulmonary bypass. However, no purported benefits of inhaled nitric oxide in congenital heart disease have been studied in a randomized, placebo-controlled manner with convincing demonstration of improved outcomes. So again, I think my experience has been that it's used primarily as a rescue drug when babies get into trouble. This is another wonderful quote, this one from Galen. It says, "All who drink of this remedy recover in a short time, except those whom it does not help, who all die. Therefore, it is obvious that it fails only in incurable cases." And I often remind my cardiology colleagues of this quotation because other than oxygen, they think that nitric oxide is the second most abundant compound in the universe. So what are the recommendations for nitric oxide? In the United States, the labeling is for late preterm, defined as greater than 34 weeks gestation, and term newborns who have an oxygenation index of greater than 25 and echocardiographic evidence of adequate cardiac output and right-to-left shunting. The recommended starting dose is also the maximum dose, and that's 20 parts per million. And we try to reduce this to 5 parts per million in the first 4 to 24 hours. Now, another reason that you shouldn't think about going higher than 20 parts per million is that the more nitric oxide you put in your gas mixture, the lower the amount of oxygen the gas can carry. And you know how sensitive babies with pulmonary hypertension are to small changes in FiO2. So by going to 80 parts per million, you may reduce the amount of oxygen in your mixture to somewhere around 92 to 94%. And you would never sell them would you ever drop the FiO2 by 10% on a baby with severe pulmonary hypertension. How long do we treat? Generally less than 5 days, with the exception being the diaphragmatic hernia baby. And here, again, the use of nitric oxide remains somewhat controversial. And I think one cautionary measure is that if you don't have evidence of an extrapulmonary shunt, prolonged use may end up getting you into trouble, because you're certainly going to downregulate the baby's own ability to produce nitric oxide. How do we wean it? We tend to decrease, as I mentioned, to 5 parts per million in the first 4 to 24 hours. When we get down to 5 parts per million, then we slow and we wean by 1 part per million before discontinuing it. When do we discontinue it? Usually when the FiO2 has been reduced to somewhere less than 0.4 to 0.6, and the PaO2 is greater than 50 to 60 for about a 30 to 60 minute period, while the baby is on 1 part per million. And we have found that increasing the FiO2 by 10 to 15% before you turn off the nitric oxide tends to result in fewer discontinuance errors. But again, you need to observe for rebound. And again, the longer the baby has been on nitric oxide, the longer it will take for the baby's own endogenous nitric oxide production to return to normal. Rebound can occur even in babies who haven't responded. So this has implications for use of nitric oxide in non-ECMO centers in the United States, and also if you have to transport a baby to a center for a higher level of care. And poor lung inflation with inadequate alveolar recruitment is the most common reason for non-responsiveness. So as I showed you, high-frequency oscillation can be combined with INO, and this resulted, at least in the United States, in less ECMO use compared to either therapy alone. And surfactant decreased the need for ECMO in RDS, meconium aspiration, and sepsis, but not in idiopathic persistent pulmonary hypertension. And that's because all of these are essentially parenchymal lung diseases that are associated with either surfactant inhibition or inactivation, whereas this is a vascular anomaly that's not going to have an effect when treated with surfactant. This slide summarizes the controlled trials. INO reduced the use of ECMO. It appeared to be well tolerated despite theoretical risks. Methemoglobin and NO2 monitoring were necessary, although now that we've adopted the lower dose protocol, we don't measure these. We do measure nitrogen dioxide as part of the administration, but we don't routinely measure methemoglobin anymore. And there is no increase in the number or types of adverse events that were reported during the phase 2 trial. There is no apparent long-term differences in neurodevelopmental outcomes compared to children treated with ECMO, and no apparent differences in mortality. So as part of an overall clinical strategy that manages parenchymal lung disease, cardiac performance, and systemic hemodynamics, inhaled nitric oxide is an effective adjunctive therapy for persistent pulmonary hypertension in term and late preterm infants. So why are people looking at other ways to treat pulmonary hypertension? And I think the answer is simply cost. Nitric oxide is among the most expensive therapies offered in the United States and Western Europe, and it's driven people to look for cheaper alternatives. I'll skip over this. And what I want to do is share with you some information that we put together about inhaled pulmonary vasodilators. And I don't know, are you using any other drugs here besides nitric oxide? I hear some people saying yes, so I'm going to assume that, that you're using either inhaled pulmonary vasodilators or sildenafil. But I just want to talk about inhaled pulmonary vasodilators because I think that this is causing a great deal of controversy, and I want you to be aware of some of the problems with these drugs. We can have two classification of inhaled pulmonary vasodilators. Nitric oxide, of course, which we've talked about, is an inhaled gas, but these compounds, prostacyclin or epoprostenol, prostacyclin or its analogs, treprostinil, and iloprost, are all being aerosolized and administered to babies who have pulmonary hypertension. Now, inhaled nitric oxide is very easy to administer. You can administer it not only through the ventilator, but by nasal cannula, CPAP, BiPAP, or even high-flow nasal cannula. But because prostacyclin is, again, a nebulized solution, you need to have a nebulizer that interfaces with whatever else you're using in the NICU. And this slide lists the devices that have been approved for non-invasive delivery of inhaled pulmonary vasodilators. I won't go through this in detail, but you can see there are no approved devices for epoprostenol. So any time that you hear somebody giving this, it's through an unapproved device. Now, let's look at the safety features. And here, inhaled nitric oxide, you see that you have gas calibration quality control. If you're using a nitric oxide administration device, you can set the amount of nitric oxide you want to deliver in parts per million. You can monitor this. You have constant monitoring near the patient interface. And in addition, you can have alarms tied to the delivered concentration. So if there is a problem, either too high or too low, the device will tell you that. And again, the safety features of inhaled nitric oxide, it has an extremely short half-life, really in seconds, and it has virtually no systemic side effects. The safety features of aerosolized pulmonary vasodilators are shown here. Iloprost has about a 20 to 30 minute half-life. It's portable, so you can use it outside of the NICU setting. So if the baby has to go for an MRI scan or some other evaluation outside the NICU, this can go with the baby. Treprostinil has a longer half-life. It's about 2 to 4 hours, and it's also portable. What are the risks? Well, they're listed on this slide. You see for iloprost, cough and dyspnea. A backup system is not required, but it's again not approved for use in conjunction with advanced respiratory support devices. Treprostinil, pretty much the same. Now, epoprostenol has no drug concentration monitoring system. There's no drug delivery concentration monitoring. There's variable airway deposition, and proximal airway deposition is likely to enter the systemic circulation because it's going to get into the GI tract and it's going to be absorbed. And there are local airway effects, which we'll talk more about in a second. Now, this is probably the most important slide in terms of understanding the toxicities of inhaled pulmonary vasodilators. And it lists on this slide the pH of commonly inhaled medications. And you can see that N-acetylcysteine, which is used in cystic fibrosis, and budesonide, which you heard about yesterday, are about the only inhaled substances that are remotely near a biological pH. And look at the pHs of these inhaled pulmonary vasodilators, okay? these are enormously alkaline. And you can imagine what that does to the delicate mucosal tissue of the late preterm and term baby. Toxicity of airway alkalinization is shown here. You get decreased mucociliary clearance, epithelial damage and sloughing, and inhibition of transepithelial transport of albuterol. Now, alkalosis isn't the only problem. You saw several of these components are also extremely acidic. And what I'm going to show you here, these are numerous conditions, catalysts, and other bodily functions. And when you acidify them, you get lots of interactions. So I'd like you to carefully think about what you're doing if you choose to use these compounds. In addition, there are a number of other issues that are related to the use of inhaled prostacyclins, off-label use. We talked about some of the problems with the pharmacy, drug concentrations, drug concentration monitoring, the delivery setup, drug delivery itself, and a host of other problems that are listed on this slide. So to conclude about inhaled pulmonary vasodilators, they're available and can be used in conjunction with non-invasive respiratory support devices. However, only inhaled nitric oxide has been approved and validated for use in conjunction with non-invasive respiratory support devices, and appropriate precautions should be taken when considering the delivery of inhaled pulmonary vasodilators. So I will stop here and be happy to entertain any questions that you might have. Thank you for your attention, and it's been a pleasure to be associated with this meeting again.
Good morning. Thank you so much for the depth and systemic presentation. And I would like to thank Mr. Meatin, I don't see him in this audience, for the correct choice of speakers. But, well, after such a wonderful presentation, I have a couple of questions to get you back to your 80s in the US, because we don't have NO in Ukraine. We have not had it. We're just hopeful that in the nearest future we might have it. And because of that, I have a question. But we have all the respiratory support, everything that you can see in the back of this audience, we have that, and sensor medics as a HO ventilator. Could you advise us with regards to what kind of mode, what's the method of respiratory support we can choose, considering that we do not have NO? What kind of level PaO2 and saturation we have to support in babies without hernia, without congenital heart disease, but with high pulmonary hypertension? And what kind of recommendations could you give us with regards to hemodynamics indices like pressure, maybe even the cerebral blood flow? So what do we have to look for, considering we have no NO, but the lung pulmonary hypertension might be there for a long time?
Yeah.
Thank you.
Those are really terrific questions, and I'm glad you brought it up. Now, in terms of, let's talk first about respiratory management. And I think the first advice that I would give you is don't treat the baby for persistent pulmonary hypertension. Treat the baby for what the underlying lung disease is. So for instance, if you're dealing with a 35-week baby who has very severe RDS, your underlying treatment is different than if you're treating a 42-week baby with meconium aspiration syndrome, even though they both have elevated pulmonary vascular resistance and evidence of persistent pulmonary hypertension. Secondly, and again, in my center, before we got ECMO, we practiced hyperventilation and alkalosis. Once we had ECMO as our backup, we radically changed our approach. We no longer tried to beat the lung for the last vestige of improved gas exchange. So we liberalized our strategy to go with the minimally acceptable PO2. And what is that level? It's whatever PO2 prevents metabolic acidosis. So if the baby has a PO2 of 55 torr, but the pH is normal, we're happy with that. We don't worry about trying to make the baby hyperoxic, which I think is just, as you've heard over and over again at the meeting, a substrate for creating additional injury. We try to achieve reasonable gas exchange with respect to PCO2. Generally like to see it no higher than 50 to 55 if we can achieve that. We quite liberally use high-frequency oscillatory ventilation with the SensorMedics device to help achieve gas exchange if conventional ventilation fails. Occasionally, we will also use skeletal muscle relaxants in these babies for two reasons. Number one, you can generally ventilate at slightly lower pressures when the baby is paralyzed, but more importantly, you can considerably reduce oxygen consumption by use of skeletal muscle relaxants so that the baby can get by on a lower level of PO2. As far as hemodynamics are concerned, again, it depends a lot on the underlying disease, but what we generally try to do is use dual site oximetry, as I mentioned earlier. So we place a pulse oximeter on the right hand and on one of the feet. And what happens is we titrate our blood pressure to avoid shunting. If your systemic blood pressure exceeds your pulmonary pressure, the right to left shunting will stop, or at least be controlled enough, and you'll see the gradient between the preductal and postductal blood gases diminish. So we use pressors, and our choice of pressor really depends on what we feel the underlying problem is. If it's cardiac output, then we will prefer dobutamine as the primary drug. If we need to have a higher peripheral vascular resistance, then we will use dobutamine, and many of these babies end up receiving both. Again, we use the echocardiogram to give us some information about contractility and filling, and if a baby has an umbilical venous catheter in place, we will connect that to a manometer and measure central venous pressure. Now, you could argue you're not getting a real number, but you can trend what's happening with the central venous pressure and make assessments about blood volume based on those changes. So I think, did I answer most of your questions? Yeah.
Thank you so much for a very interesting presentation. We don't have the opportunity to use NO, we use sildenafil. What is your experience using sildenafil? Can it be a kind of an exchange drug to use?
I'm always embarrassed when people ask me if I use sildenafil. Not personally. I have gone around to many resource-limited countries, and they do use sildenafil in this instance. And I think it's probably not works through a similar mechanism. It's a phosphodiesterase inhibitor, which results in pulmonary vasodilation. The problems with sildenafil Number one, it's extremely difficult, if not impossible, to monitor. Number two, you don't know how much of this drug, if you're giving it through a nasogastric tube, you don't know exactly how much of it's being absorbed, and we don't know anything about drug-nutrient interaction. So if you're feeding the baby and you're giving sildenafil, is it being inactivated? Is it being bound? We don't know. Now, having said all that, it is a very reasonable alternative if you don't have a defined pulmonary vasodilator, and I would certainly think it's going to be safer than the prostacyclin and its derivatives that I showed you before. And I guess the other question is, how long do you treat and how do you wean it? And I don't think we have the answer to that. So it will depend upon your own institutional experiences.
Thank you very much for this wonderful presentation, very relevant, vital topic. Thank you for answering our questions. Also, we are interested in the following. Number one, you mentioned that NO decreased the use of ECMO by 50%. Can you tell us, please, how early, I mean in terms of age, how early do you use nitrogen in the like in the maternity hospital or intensive care unit, or maybe later? How often? And second question, concomitant use of exogenous surfactants. So what's the interaction here? Thank you.
Yeah, I wasn't clear when you said age, if you meant postnatal age or gestational age.
Well, both. Postnatal. Well, let's say postnatal. How early? First day, second day, third day, 7th day, 7th?
Yeah, we started as soon as we have diagnosed pulmonary hypertension. So it can be as early as the first hour.
So no limitations. Okay, I got it. Thank you. And second, number two, with regards to exogenous surfactant use.
We use exogenous surfactant again for most of the conditions associated with persistent pulmonary hypertension, unless there's no parenchymal lung disease. As I mentioned, it doesn't work in those situations. And the indications that we use are adopted from the RDS criteria. So if a baby has an AA gradient of less than 0.2, or is requiring more than 40% oxygen, or is on a ventilator at significant high settings and has poor compliance, we would use it.
Thank you. Thank you very much for your presentation. I have a couple of questions. In your presentation, you showed a lot of information on oxygenation index, and then you mentioned, so you choose the 25 oxygenation index for your setting. So what's the basis for high oxygenation indexes in other studies, around 40, 45 to start NO therapy, but you have 25%? So, and the second question that I have, you mentioned that monitoring is mandatory on hemoglobin, and you mentioned you don't routinely use it. According to the protocol, what kind of monitoring would you recommend? How often in the beginning of NO therapy?
Okay. First, regarding the oxygenation index, this number was chosen based on some preliminary work in the pre-ECMO era, where retrospectively babies who went on ECMO versus those who didn't were compared, and what we found initially was if your oxygenation index was 40, now the oxygenation index is really an efficiency number. It's derived from the FiO2 and the mean airway pressure divided by the PaO2, and you multiply that by 100 to come up with the index. So an oxygenation index of 40 had an 80% probability of death. So we use that as the absolute number. If a baby hits 40, he or she has to go on ECMO. 25 doesn't have a predictable value, but based on the numbers, it was chosen because it gives you enough time to do things electively rather than emergently. But again, there are no hard data to support that number. And I think that, as I said, we were the original ECMO center, and I can tell you that in 2018, if a baby has an oxygenation index of 40, that baby is a lot sicker than the baby in 1980 who had an oxygenation index of 40, because it involves a lot more therapy and a lot more care. So that's why we use the 25 to 40 as an intermediate zone. Your second question was related to monitoring. And as Reese Clark showed, that the toxicity is almost non-existent as long as you don't go above 20 parts per million of nitric oxide. We used to measure methemoglobins once a day when we were using more than that. And only once or twice did I see a baby even come close to 4% of methemoglobin. So we just stopped monitoring it now that we never go above 20 parts per million. And we do monitor the NO2 and the NOx. That's part of the drug monitoring system.
Thank you very much. And also weaning, NO weaning. So how long does it take? So when you go down to 5 ppm dose, how long does it take to wean? Couple of hours or one day? How long does it take to wean?
Yeah, the weaning is very patient specific. What we do is we try to get down to that 5 parts per million and then wean by 1 part per million. We try hourly. Sometimes we get stuck at 4 or 3 or 2. And have to go a little bit more slowly. But it depends to a large extent on how long the baby has been on nitric oxide, what the underlying pulmonary hypertension has done. And so I can't give you any hard and fast rules other than to say, try to get down to 5 as quickly as possible and then go slowly.
And a small question with regards to your center. You mentioned that you work in one of the biggest, largest centers, ECMO centers. How many babies, newborns on ECMO with PPHN you have in your center? And what's the minimal body weight of a baby for on ECMO and gestational age? So when NO is not efficient, so you do ECMO. Yeah. Thank you.
At our peak, probably between 1985 and 1990, we were doing 120 cases per year. So about 10 babies a month, 2 or 3 babies a week. Our use now has declined dramatically since the advent of nitric oxide. We barely do 20 cases a year, and almost none of those are for persistent pulmonary hypertension, except in the diaphragmatic hernia population. And I think this has been pretty much the experience across the United States based on the numbers that are being provided to the ELSO registry. In terms of size, again, it's an individual basis. Our guidelines say minimum 34 weeks or 2 kilos of birth weight. However, we have done more immature babies and smaller babies on a case-by-case basis. The limiting factor is the risk of intracranial bleeding. Because you have to systemically anticoagulate a baby, in the early days, we did babies as small as 750 grams, but we found that there was an alarmingly high incidence of intracranial hemorrhage, and not just your garden variety subependymal hemorrhage. These were major parenchymal bleeds, and so we stopped doing premature babies pretty quickly. But we will evaluate on a case-by-case basis, and it's not unusual for a 32-week baby to be treated if it's the last resort.
Okay, and to continue with the question, with increasing levels of methemoglobins during inhalation with NO and other cases. So what do you do about that, and what are the values that you consider to be critical that you start to decrease methemoglobin? Thank you.
Usually 4% is considered an interventional point. And I think only once have I had to treat it, and I used methylene blue.
Thank you very much for your presentation. I have a practical short question. We do not have a possibility to use NO, nitrogen monoxide, and develop such kind of therapy. But could you tell me, if we compare intravenous L-arginine as a donator of NO and inhalated prostacyclins, in practice, what would you prefer? What would be more preferable?
Good question. I suspect that there are fewer side effects with L-arginine, which I use occasionally for babies with urea cycle defects. It's a whole different story. And the only side effect that I've encountered with that is occasionally metabolic acidosis, because it's an HCl salt. Judy Ashner has done some work with using citrulline also as a treatment for persistent pulmonary hypertension. So if you have experience and you have the drug available, you certainly could try it. If you have inhaled are we talking intravenous or inhaled prostaglandins? Intravenous, yeah. We have occasionally used intravenous Flolan in babies who have had refractory pulmonary hypertension. The problem with Flolan is that it requires a very large volume of fluid, and so that may limit you in terms of its long-term use. But if you have both drugs, why not design a trial? Answer your own question.
One more question, if I may. Dear Professor, could you tell me if during the treatment of persistent pulmonary hypertension, it is possible to make use of magnesium therapy? If yes, what could be the dose, what would be the duration of magnesium injection, and what would be the course of treatment?
The only paper that I'm aware of was published in Archives in the early 1990s. And I'm trying to remember, the author had a hyphenated name, and both names began with the letter O. I just can't remember his name. And he published a case series of magnesium sulfate for the treatment of persistent pulmonary hypertension, utilizing its vasodilation properties to treat the pulmonary hypertension. So I would refer you to that paper for the dose and duration, because for the life of me, can't remember it.
Thank you so much. My question was evoked by the fact that during one of the conferences, we had a chance to listen to a very cognitive presentation regarding hypertension treatment. And the speaker was from Great Britain. She was sharing some personal experience, and she said they were quite widely making use of such therapy at the delivery room when the diagnosis is found with the use of echocardiography. And then all other interventions and other therapies would be done when you do not receive a good response from that very simple intervention.
Mm-hmm. Okay. Thank you.
Thank you very much for presentations. Now we have in our country very dramatic situations, and now we have a tendency to be in low-income countries. But due to the very nice activity for Pinchuk Foundations, I'm very proud to be in a group of doctors in this department, in my department, and in many departments in Ukraine. We have very high-tech equipment due to the activity found Pinchuk. It's a very nice possibility in our country too. But my question is, do you use hydrocortisone in the treatment in persistent pulmonary hypertension? Hydrocortisone you use?
I'm sorry, I couldn't hear you.
Hydrocortisone. Hydrocortisone.
Oh, hydrocortisone?
Okay.
Yeah, it's sort of a third line treatment for hypertension. So usually we try volume expansion, dobutamine, dopamine, and then hydrocortisone.
What dose you use?
Usually about 0.25 milligrams per kilogram every 12 hours.
Okay.
Occasionally higher.
Okay. Can you comment situations in use nitric oxide in very premature baby? In USA and Canada, it's not allowed. It's many centers use off-label in very premature baby nitric oxide.
Yeah, that's a good question, and you know, we used to say many years ago, you can't die without steroids, and I think that's now been replaced with you can't die without nitric oxide. It is probably among the most off-label used drugs in the United States. And I have a little bit of a concern about it because, number one, it is off-label. Doesn't mean you can't use it, but it means that you're not likely to get reimbursed for it, so it becomes a very expensive proposition. Number two, the more immature a baby is, perhaps the greater the risk of adverse events, and we have no long-term information about what happens to developing organs that are exposed to exogenous nitric oxide. And I think part of the issue that I see is we tend to label everything as pulmonary hypertension, and if a baby, especially a preterm baby, has parenchymal lung disease, that's going to cause an increase in pulmonary vascular resistance. Now, that doesn't mean it may not respond to nitric oxide, but it's not the same disease that we're talking about in the term or late preterm baby who has one of those elements of pulmonary hypertension. So the Committee of Fetus and Newborn has been very specific about limiting the use of nitric oxide to babies who are 34 weeks or greater. And there was an NIH consensus workshop that came to the same conclusion.
Mm-hmm. Thank you. If baby have very early percent pulmonary hypertensions, and this baby have very severe ADS, maybe in the future this baby will have severe bronchopulmonary dysplasia. Yeah?
Probably.
Thank you.
Mm-hmm.